So our next speaker is a member of our roundtable, a longtime member of our roundtable, Catina O'Leary, who will address the health literacy principles embedded in the approaches we heard about earlier today from our other speakers. Dr. O'Leary is president, I prefer to say Catina, but Dr. Catina O'Leary is president and CEO of Health Literacy Media. Previously, she was a faculty member at Washington University School of Medicine in the Department of Psychiatry and the program on occupational therapy. Catina, all yours.
You know, it's funny, I should say that when he gives that introduction, when I was at WashU, I worked with Linda Kotler. She trained me on all these things. So it's really cool to be in a room where you get to talk in front of your mentor and person who taught you everything about the things that you do with what she taught you. Ditto, right? So my job today is to integrate some of the things we heard before, because our experience as a roundtable is that we pick a topic like this and we bring people in who are experienced in the topic and those experts, but they're not always as grounded in health literacy as the roundtable would like them to be. And so sometimes they ask people to come in and sort of bridge those conversations and connect the dots with health literacy. And as you probably imagine, the people in all of the presentations so far today have not had that problem. This has really been the first time I've ever seen where all the speakers use the health literacy words, they use the language, they were as oriented as we've ever had. So my talk has been changing for the past 4 hours because I keep thinking, oh geez, that's not going to be useful at all. The thing that Bernie didn't say in my bio, though, is I'm a social worker by training, and I spent a lot of years doing mental health work. And I did that because my mom ran the largest mental health and substance abuse treatment center in Missouri, and she did that for about 43 years. So she had the whole sort of quarter of the lower edge of Missouri, and she was the executive director and the CEO of that. And through that, what happens when your mom runs a treatment center in rural Missouri is that you provide services and treatment when you're a little kid. So my earliest sort of professional experiences were being a treatment tech when I was about 17 years old at a substance abuse residential treatment facility for young kids. But even earlier than that, sort of being the family that went to deal with holiday outages because everybody else wanted to be home with their families. And so I played a lot of cards and sang a lot of songs in treatment centers. Because that's what you do when you're in rural Missouri and everybody wants to be off and you have to staff things. So all that to say, this is really near and dear to my heart. This is the topic that's most important to me. So I'm really excited to be able to put these pieces together. So my job today is I'm going to give a little context to some of the things that people said, but again, not much context really needed. I'm going to tell you a little bit about a project where we applied some of the best evidenced health literacy strategies to a mental health provider in Missouri and tell you about how that went. And then give some thoughts on recommendations to move forward because why not? And like Dr. Compton said today, we don't all share a language on definitions. So I think this is also part of this is to put the words together so that we make sure we're all talking about the next thing before the last panel really starts to tell us where we should be going. So we haven't seen this all day today, but if we're going to connect dots, this is probably one of the more important ways that we could connect them, is we can talk about health literacy literate organizations and where the interventions that we hear people talking about land and live in this space. So what I heard across the day is people talking a lot about shared decision-making and patient-centered, integrative, collaborative care. I heard people talking about user testing. I heard people talking about meeting people where they are in communities, including social online communities. So they're not even seeing each other necessarily. All of this to reduce the burden and make interventions meaningful and as usable and accessible as possible. People were talking about design features in web and social. And then they were also just really talking about how to scaffold and teach people and help them grow and learn. So if you're looking at this chart here, you really see a lot of this in the areas of including consumers, meeting the needs of all people who need things where they are, designs that are easy to use, targeting people high risk for problems in specific areas, communicates effectively. I mean, that was the story of the morning, is communication effective or not, thinking about how we evaluate, plan, and improve. And obviously much of this is leadership issues that ensure access in multiple places. So we heard all of that. We did a really good job. I want to say congratulations to these speakers. I've never, ever, ever heard this happen when we bring so many people from fields that are not health literacy that just hit it out of the park. So that's awesome. So I don't have to say much of this because they already said it again. This was backup in case they didn't say it, but a lot of people have serious mental illnesses. What no one really said this morning, I don't think, is that a lot of folks are untreated. And in some states, about 70% of people are untreated. So they're out there sort of navigating the world. We talked about where we see them, sometimes in collaborative models and sometimes in mental health problems models, but not really. We didn't spend much time talking about where people are showing up with physical conditions who also have mental health conditions that are not being attended to. So putting that on the table. There was also some discussion today about rates of death in people with mental illnesses and serious mental illnesses. But the figure that comes from Missouri, Joe Park's study says that they die about 25 years early. So if you think about sort of losing a quarter of life because of a mental health condition that's untreated for all the reasons that we talked about before. Here in a health literacy space where we think about both sides of the equation, so the system level factors of fragmentation, we've talked about sort of EHRs and provider barriers, but we've really not talked about that problem with people having separate providers and not getting to the right place, except for in the case of collaborative care where it works really well. But that's not the reality for most people. Most people are having a really different model where they're seeing providers who are not connecting all the dots for them. This is always sort of complicated to say, but another factor here is we have behavioral health providers who are really well-trained communicators who are doing much of this work, but they don't actually get much training on health literacy and communication about how to communicate about health. So they get trained on how to communicate and connect with people at a patient level about sort of social interactions and what's going on in your life and how to make you understand your health condition. But that idea of how to help you think about the treatments and execution and implementation is not necessarily something that everybody is doing. But again, we're learning with motivational interviewing and some of the other strategies that's getting better. So that's a really good thing. But then there's also the provider factors just associated with medical treatment, with the competing demands. And we talked about stigma a lot. And then just the poor training on communicating with people about mental illness. We were talking about this a little bit at lunch, the fact that nobody wants to be the one to give bad news. So telling a family that their child has schizophrenia, talking about the fact that someone's suicidal, telling somebody that they have a rare disease and the person's going to die. Nobody wants to do that. It's really uncomfortable no matter how often you do it. And we've learned through lots of data that providers communicate that discomfort over and over again. And it doesn't matter how skilled you are and how many times you've done it. Most people still don't enjoy doing it. And it's not an easy thing to do. And that struggle leads to less access. And then, of course, the client factors that we've been talking about, motivation, feeling fearful, social instability. All those things lead to increased risk of death from preventable disease, which we've also been talking about a good amount today. And there are all kinds of factors that increase risk and lower access. So these vulnerabilities that we've shared. And then really people talk a lot about being stigmatized by providers. So this idea that primary care is reactive to a condition and it's sort of time-limited experiences. And we know that primary care providers are often have a feeling of inexperience or uncomfort or bias even associated with these patients, and there's just not enough time. So I really appreciated Mike Wolf's comments this morning about how do we figure out who needs more time. We do that in education all the time. If a person has a disability, for example, and they need more time to study or take a test, there are forms to fill out and something happens. People get more time and there are accommodations, but for whatever reason, those accommodations haven't really been carried over into medical care in a reasonable way. So we got to figure that out, and it seems like an easy thing to do. I mean, it seems sort of like a dumb moment of, have we not done that? But we want providers and people to care about it because stigma results in all kinds of things like medication adherence problems, treatment dropouts, no-shows, people who come sicker to help or care, and also just a lack of physical care. All kinds of barriers to communication that we've talked about. So these symptoms, increased anxiety, paranoia, decreased attention and concentration, superstition, voices, all of that interferes with a person's ability to do what they want. We heard people talk about this morning. They aren't able to do what you want or what they want. But this trauma from treatment that our very first speakers talked about. I don't think we spent enough time thinking about how what we do causes increased problems and keeps people from getting care over and over again. And it doesn't even have to be their own trauma from treatment. It can be connected to the people in their family or other folks. So as I'm hearing the stories this morning, I'm thinking, gosh, like something like that's happened to me, and that makes me not want to see a certain provider. And I'm sure that that's significant for lots of folks. So there's a really good set of materials that came from a group of folks out in California, and I think Sam has also put together some of these things, but they talk about what clients say. So I just provided these quotes. I'm not going to go through and read them all, but in the materials, just thinking about this idea that people assume we're not reliable witnesses to our care. So this whole idea that somebody else has to report on you all the time. In health literacy, we think about the fact that there's a dynamic communication process. So sometimes I'm able to understand and sometimes I'm not. Well, the same is true in mental health. Sometimes I really know what's going on. Sometimes my family members who are struggling with mental health really are absolutely able to report on themselves with remarkable clarity. And sometimes they're not, right? And when they're remarking with clarity, sometimes when they're maybe in a manic state, they don't get believed even if they're dead on. Right, like somebody's asking me to do that for them. So what's that like, even when you're exactly perfectly right and you know exactly what you need and all the people around you don't believe you and don't let that happen for you? So they talk about that. They don't like to be rushed. They want people to look at them and listen to what's really going on and take the time, which we heard earlier today. They talk about the fact that people think your brain is broken and they treat you like that. So the same idea that we think about in certain communities where if a person speaks another language, we just speak louder and slower. Same thing with mental health. We're going to speak louder and slower and treat you like you're really unclear or dumb when in fact that's not what's going on. We talk about the number of medicines, the questions that people don't like to answer, and really the glossing over of important risks, because we all know, and I don't think we've said anything about this today, these medicines that we ask people to take to deal with the symptoms of their psychiatric disorders are really, really horrific for a lot of folks. And there's good reason people don't all want to take these medicines, and we don't have the kinds of conversations we should have about what's acceptable risk and what's not. And this is a good quote. I get really scared because who'd want to take a list of meds for something they haven't been educated about? So we move people toward the solution before they understand the problem. But some people do this really well. So we heard about collaborative care in other cases. So we hope that rolls out and it spreads and it happens more clearly. One of the things we didn't talk a lot about today either, though, is some basic best evidence health literacy strategies that can also be applied in this population. So we've done some of this work in Missouri, I'll tell you a little bit about, where we've done basic things like health and environment assessments, plain language materials, symptom-based communication strategies, and real use of empathy. Wilson Compton said this earlier today, like what your mother and your grandmother teach you. So humanness, kindness, and empathy go a long way working with people, period. Here are some basic guidelines that we borrowed from somebody that I think are really useful, though. Patients say that they'd like 2 minutes to talk without interruption. And this is a really easy thing to remember. So if you've got a 15-minute visit and you just devote the 2 minutes to let them speak, it goes really a long way. People want to hear the illness, its important, and the impact using words they understand. They want written information they can understand. And we talked a little bit about why are we still giving people papers when they don't read well. Well, part of the reason we give them papers when they don't read well is so they can take it home and they can look at it again with people who do read well, and they can remember and reinforce. And we don't have to put a lot of text on those papers. And that's the trick, is if we use the pictures and white space and images that make sense to people and graphics that work, and we talk with them and we build those scaffolds, that piece of paper that they can't read is still very useful in many ways. But we can obviously provide some multimedia support as well. And we can do more than written information, but written information isn't dead. We want to explain the medications and address all the concerns. They also say that they feel like there's an assumption that symptoms are all in their head, and they don't appreciate that. And they want the treatments, any of those treatments related to those symptoms, connected to their own goals. And this is where you get to the patient-centered part of this is, we can work together on collaborative goals, but then we have to use those and keep those going and keep them in the conversation and make sure that they stay relevant. They want encouragement and participation in peer support groups. So people out there who have lived the experience provide a lot of support and education and advocacy, and patients appreciate that, but they say that they don't always feel like that's viewed as an important part of their treatment and recovery as some other interventions. And then the final thing I'll say is that they really want to be seen as a whole person. And that's really just humanity again. We all want to be seen as a whole person, not a condition. So we partnered with Truman Medical Centers. We finished this about 2 years ago, and we had funding from the Healthcare Foundation of Greater Kansas City because they had a focus on mental health. So we partnered with these folks to figure out how to implement our best evidence strategies. They're the largest provider of mental health services in the Kansas City metro region, and they have about 17,000 clients each year and about 200,000 outpatient visits. So our whole role was just to do what we always do. So we provided trainings on health literate communication skills. So we had all of these behavioral health providers who didn't really have any prior knowledge of verbal communications or written communications and all the sort of standard interventions we did. So we did that 4 times with them. We did health environment assessments at all 5 of their facilities, and we found exactly what you would expect to find in those facilities, and they were able to take some actions to change their facilities. We reviewed and revised tons of their existing client-facing documents, and we created some new ones. And the cool thing about how we created these new ones, though, is we went into their meetings where they were doing case management, and we talked about the problems and the questions that they get over and over again and try to answer on the spot. And we helped them create materials so that they didn't have to train people to come up with the answer over and over again. They could actually have a piece of paper that was factually correct and health literate and accessible, and they could speak the answer, but then they could also support it. And that was really important in a facility like this where there's a lot of turnover and a lot of lower educated staff, people who don't have a lot of behavioral health experience, people come and go. So retraining people over and over again on materials that are outside their skill set isn't really a workable solution for folks. So again, there was all kinds of problems with navigation, and we know that that influences people's mental health. If you've got a mental health problem and then you're stressed because you can't find your way, that's really a problem. But also their functional ability and their safety. It was really an issue for them. And then also poorly designed facilities reinforce negative behaviors and promote all kinds of issues with patients who are having troubles. The materials didn't help them provide the education they needed, and they weren't tailored at all to the population. So we helped them with that. And then patients in this community were starting at a lower level of health literacy. So I don't think I have to tell this room how important plain language is, but I'll just say on the slide, plain language is a really big deal. And we're thinking about plain language in the way that it's language that works for the people who are the receivers, and they ought to be able to understand it the first time, and you got to test it to know. So it doesn't matter how smart we all are, and it doesn't matter how many other times we've used that word. If you don't go to the people you're serving and ask them if it works, you've missed the mark. And I can assure you, something on the page that you turn around is wrong, like dead wrong. And they don't know what you're talking about, or it means something else, and you're embarrassed. But you maybe don't even know you're embarrassed. But we want to make that work, and we got to test it. So we did that. We want it to be easy to read and understand, really beautiful and visually appealing. Speaker in the last session talked about all those tips that were just beautiful and perfect. But we had to teach the managers and key staff how to identify, revise, and write documents that did this, because we couldn't give them everything they needed forever. So one of the things that we did is created templates, and then we trained them to use the templates so they could make the updates and turn them over and create them again. And this is a really low-cost way to empower staff and make sure that they always have what they need. So here's an example. They chose this branding. They're really interested in characters. They serve a diverse community, and they didn't want pictures of authentic people because it reflected too much diversity and complexity in their community. So they asked for characters that were animated, and this is the color scheme that they chose. But you see that we use pretty standard plain language and health literacy principles like headings and bullets and color and all that good stuff. Here's another one on caffeine. Caffeine was one of the biggest problems that they had to address all the time with some medications and the way that people moderate their own moods with caffeine. The doctor said that they were constantly sort of struggling with that and tobacco as as issues, and so they needed a resource to talk about how to measure caffeine and think about how you're drinking water and other things and not just caffeine. And then obviously some symptom-based diagnosis materials. So what we know is staff need to be able to identify and choose materials so they can make their own or they can find them out in the world, but they can't be expected to create and participate in treatment plans without anything to help them do that, right? Like we can't just generate activity and energy all the time. So they need to know where to get them, how to know what works and what doesn't, how to know what's good. They need to access them, and then they need to be supported in using them. And they need to be used as supportive of spoken instruction, not as a replacement. So this again gets to the point earlier of why are we giving people print materials? It's a backup. So just getting to the end of this, thinking about recommendations. So there are all kinds of things we can do, and I heard people talk today about designating people with serious mental illness as a health disparities population. Sometimes people do that, sometimes they don't, but we don't talk about it often when we talk about social determinants of health and other big issues. We sort of leave this off and don't address it as much as we could. We don't do a good job or as good a job as we could at surveilling and thinking about all the different categories and who we're actually talking about. And we can support education and advocacy. At a state level, we can improve access to physical health care and link the mental and behavioral health care to that and make sure that it's really integrated. And we can talk about what funding is for these initiatives. And I really appreciated in all the panels today talking about where funding comes from and who's providing it, and all the interesting ways that people are sort of creating a patchwork of funding to support their work. The mobile healthcare provider, I think, did just a really interesting job of telling us how you put something together that actually was useful. From an agency and clinical perspective, we can talk about policies that mental and physical health are integrated, and then help people understand messages of recovery and implement these care coordination models that we've been talking about all day. And then, of course, for families and communities, thinking about the fact that we said 1 in 5, and I really think that that's probably an underestimate. I think if I were to ask the people in this room who either themselves or someone that they're sort of a direct first-degree relationship with struggles with a mental health condition, I'd be shocked if half the people in the room didn't raise their hand. I think it's probably more. I think we can all identify somebody directly in our first level of touch that really struggles with mental health and related conditions. And it's maybe not all the time, but sometimes. And when it happens, it's sometimes really a big deal. So we need to encourage people to really think about what integrative care looks like, how we partner together, and how we think about person-centered care that's really focused on recovery and wellness. I said a little bit of this before, but we can think about the relationships between mental health and health literacy, right? So we think that they sort of overlay a little bit. I think it was Mike Wolf. Somebody provided a slide earlier today, and it was like a map. If you laid one thing on top of the other, they almost looked exactly the same. And you think, well, gosh, it was Mike Wolf because he said if you got rid of these conditions, you'd still have a health literacy problem. And that's true, but gosh, it's so closely connected. And if you think about those ties, I think it maybe helps us do a better job with the people we serve. And we can do our work to really train medical staff to increase patient understanding, think about how we assess our systems, and really educate folks to use our best evidence practices. And I will stop now.